5 years to 2030. How are countries doing in the race to meet these targets? Global Health Digest has some answers, but that will be after the backgrounder. I am Uche Ugochukwu.
Universal health coverage, also called universal healthcare, is a healthcare system in which all residents of a particular country or region are assured access to healthcare. Universal healthcare does not imply coverage for all cases and for all people, only that all people have access to healthcare when and where needed without financial hardship. Some universal healthcare systems are government-funded, while others are based on a requirement that all citizens purchase private health insurance. It is determined by three critical dimensions: who is covered, what services are covered, and how much of the cost is covered. The first move towards a national health insurance system was launched in Germany in 1883 with the Sickness Insurance Law. Industrial employers were mandated to provide injury and illness insurance for their low-wage workers, and the system was funded and administered by employees and employers through sick funds, which were drawn from deductions in workers' wages and from employers' contributions. This social insurance model, named the Bismarck model after Prussian Chancellor Otto von Bismarck, was the first form of universal care in modern times. Beyond the 1990s, many countries in Latin America, the Caribbean, Africa, and the Asia-Pacific region, including developing countries, took steps to bring their population under universal health coverage, including China, which improved coverage up to 80% of the population. The universal health coverage was adopted in the 2030 Sustainable Development Goals (SDGs) in 2015 at the United Nations General Assembly high-level meeting.
This is Global Health Digest on NTA International. The concept of universal health coverage stipulates everyone, everywhere, should have access to the health services they need when they need them without facing financial hardship. Is this the reality for many? Our crew finds out from the streets.
I was once there in my community down in Doma local government. I'm from Nasarawa State. I don't have any issue there, and to some extent the facilities there are a bit okay.
What I observe personally, like the pharmaceutical area, the drugs, government to do more to subsidize. So if the drugs can be made free and available, it will be easy then for the government and to be able to improve the health care of the people.
Well, I think it will be very, very difficult for any country or any government to have 100% of healthcare facilities in for the citizens. But however, as far as Nigeria is concerned, I think our government is doing its best, though it is not that satisfactory.
For many, accessing quality health care means long wait times, unaffordable treatment costs, or simply not having the necessary infrastructure, with the poorest and most vulnerable suffering the most. WHO in 2019 estimated that over 800 million people were pushed into extreme poverty due to health costs. The 2030 target aims to eliminate these barriers. What's the situation in Nigeria? Director General of National Health Insurance Authority, Dr. Kelechi Ohiri, tells us.
What we're trying to do is a couple of things. One is to, first of all, we emphasize primary health care as the foundation for universal health coverage. We want to run a system that is based on prevention and primary care, not that people will wait until they become sick and receive care. So a lot of work has been going on in expanding access to basic primary care services. The second has been what really applies to me, which is financial access. And that is to expand coverage so that those who are financially protected from the cost of health. What does that mean? It means that it's one thing for the service to be there, It's another thing for you to be able to afford it when you go to the hospital. And where NHIA comes in is that we know that financial protection through insurance is an effective way of enhancing access to care. For the past, say, 20 odd years, when NHIA has been in existence, those who really benefited from it were those formally employed, like government officials and the organized private sector. But that has changed. And this started with, the National Health Act that introduced something called the Basic Healthcare Provision Fund in order to actually accelerate this progress. And a couple of things were done. One was that something called the Vulnerable Group Fund was established to crowd in a lot of resources that are intentionally targeted towards the poor and vulnerable in our society. So this is a game changer because it means this financial protection is not just for the wealthy, it's not just for those in the organized private sector or public sector. It also will bring in those who are poor and vulnerable, the disabled, women who have suffered from major maternal morbidities like DDF, etc., displaced persons. But resources have been allocated to this, and we have seen that this year alone, an additional 600,000 people were also covered with that, bringing the number of those covered in Nigeria to about 2.4 million people who are poor and vulnerable people that are covered. Now, in addition to this, we didn't stop there because this financial protection has to reach more people. And so from a baseline of about 16 million last year, we're at about 19.2 million people now. So this year alone, we've added about another 2.5 million, 2.6 million people on health insurance. So can more be done? Yes, but we're definitely on a steady, impressive trajectory. And this is probably one of the fastest growth rates in terms of insurance coverage we've seen in recent times in Nigeria. And this has been a collective effort of both the NHIA, the state health insurance schemes, the private health insurance institutions, and other stakeholders coming together to really take on this. So that's another thing the government of Nigeria has been doing, making sure that we're expanding that. Some of the additional interventions that have been taking place include things like we know that Nigeria has one of the highest maternal mortality ratios in the world, unfortunately. And in order to make sure that that access to care for women when they are delivering and maybe they have some complications, that finances do not become a barrier to that. Because in that 48 hours, it's life and death, right? If a woman is bleeding and shows up, that's not the time to ask too many questions. That already creates a level of vulnerability that should be addressed. And so what the coordinating minister announced and what we're doing is we're identifying what the leading causes of death is for mothers. And we're saying that when you present and you're unable to pay, NHIA will step in and make sure that care is paid for so that women who are in that vulnerable state do not get turned back. And then after that, we make sure you get insured so that subsequently things that you need, not just related to childbirth, but other things that are covered in the benefit package are covered and you are protected going forward. But then there are some women who do not die, but are left with major morbidities like obstetric fistula. And we've also extended and started that program where if you find a woman that has obstetric fistula, most likely she's young, she's poor, she's been ostracized from society. And so as part of this equity imperative, we're saying that same thing, anywhere in Nigeria, there's a woman that as a result of childbirth or whatever has obstetric fistula, show up in a center, and then that care will be paid for in its entirety. Feeding, care, surgical interventions, end-to-end will be paid for, and then you will be enrolled in the social health insurance scheme that is available. There are three things that make us optimistic that this trajectory will be sustained. I think the first thing is that with the NHIA Act in 2022, health insurance is now mandatory, which means all residents in Nigeria should have a form of health insurance that meets at least a basic minimum standard. We are working right now with the relevant government authorities that have the mandate to help us enforce this across government, but also across the organized, private sector as well. In addition to that, we're also working on how we bring in the informal sector to be covered by this. But it's law, it's mandatory. So that gives the extra impetus for people to get coverage. But we know that that's not enough. So the second thing that relates to that is awareness. There is a lack of awareness of insurance in general as a mechanism, and more so of health insurance. Part of it is cultural as well, because we come from a culture where we do not believe in looking for problems. So some people may have the misconception that if you get insurance, that means you're inviting problems. And like some people say, their biggest competition as insurers is, it's not my portion, which is, related to our cultural beliefs, etc. But also there's misinformation about what entitlements people have and how insurance works. And so our work is cut out to make sure that we partner with civil society, the media, and other stakeholders to make sure that more awareness is created and let people know that insurance is a better way to pay for health services, because it will require you to pay and look for the actual costs at the time of need. So a lot more needs to be done. But lastly, I think the third thing that we need to do more of, and why we know that we can actually drive this, is rebuilding trust. And that trust means that when you're insured, and if I'm insured, it should mean something similar to both of us. It should mean at least that if I'm ill and I go to a hospital, for whatever it is that ails me, of course, within the benefit package that I have, which needs to be reasonable. But the second thing as well is that not only should you address my issues, but also I shouldn't leave there paying a lot out of pocket. When I came into this role, one of the things that I instituted was actuarial studies, so that we could actually look at, for the benefit package that we offer people, how much should that be by way of the premiums that are paid and the tariffs that we set. And this work has been ongoing. But given the criticality and how rapidly prices were rising, we had to intervene. It was an intervention. And we increased capitation by 60%. And the fee for service paid out by 40%. And this was in consultation with providers, public sector, private sector, medical associations, HMOs were there, several development partners, WHO. It was a very broad-based consultative process, looking and also based on us looking at tariffs, etc., that has since sort of stabilized the market. We're still wrapping up our actuarial review, and we'll probably review the tariffs again, depending on what the numbers are telling us. And so what this means is that the number one cause of people being denied drugs was what we tried to address by increasing these tariffs. And we have ramped up our enforcement in that regard, so that we've had cases where people have been denied drugs and then they complain. And then when they have to buy drugs out of pocket, they get reimbursed immediately. But we don't want people to pay out of pocket. So what we're looking at is how to tighten that to make sure that the enrollee, for an enrollee charter, you know what you're entitled to and you know what you can demand. But first was what we did, which was let's increase the tariffs to make it fair, because you come to equity with clean hands. And so we heard our stakeholders and we went ahead and increased that so that there will be no reason to actually deny our enrollees, because our enrollees are a priority. And so that has been done. And if you go to a facility and you're denied care, or the drug is out of stock or whatever, complain to the NHIA. We will intervene and make sure that is done. But I'm very sure that with these reviews that have occurred, such situations will become less frequent. Even with the guidelines from the Ministry of Health, even personally as a doctor, when you prescribe, you should actually prescribe a generic name of the drug. And what you want is a drug that is safe, that is efficacious, and that has been approved by the necessary regulatory agencies. And so for every drug, say paracetamol, there could be 5 different companies or 10 different companies that make paracetamol. And when you're ill and you need an analgesic, it's paracetamol you need, not the brand name of the drug. And so what we do is we ensure that first is the effective drug that is provided, that has a generic name. Now, when it comes to pricing of the drugs, we know that in many instances, generic drugs may be cheaper because the brand name drugs usually start off first. They have the patent protection and they can charge monopoly prices. When the patent lapses, new people can come into the market and make the same drugs of the same quality and efficacy. Now, how you choose to price your drug, that's for the manufacturer. The regulation of the quality is for NAFDAC, and once the drug is regulated that it's effective, then it makes sense from a cost-effective perspective for you to, in the hospital, to provide the drug that is cost-effective but very effective for the patients to recover. And so it's important as part of our awareness to let people know a generic drug is not inferior to a brand name drug.